Welcome, friends, to another episode of NTB Dialogues. Since 2011, when we hosted the first NTB Dialogue, we have come a long way, but so has the TB response. Science and evidence has powered the TB response in high-burden countries. We are finding TB better than before. But still, major gaps remain, due to which millions of people with TB face catastrophic costs and diagnostic delays. When we fail to diagnose early and accurately, we fail to stop the spread of infection too. Today we have amongst us our friend Joshua Brianwong Clark, who has won the prestigious Joep Lange Award 2026 for his high-impact study on data-driven deployment of an AI-powered mobile chest X-ray van to accelerate TB detection in Eastern Uganda. We happen to be fortunate enough to have known Professor Joep Lange. He served the World Health Organization HIV department 3 decades back, and he also led the International AIDS Society as its president over 2 decades back. We salute Professor Lange's contribution in advancing HIV science. Unfortunately, he was on the ill-fated Malaysian Airlines flight in July 2014 that was shot down. He was coming to the International AIDS Conference, or AIDS 2014, in Melbourne, Australia. Not just me who was at AIDS 2014, but the entire global health community was shell-shocked. It was a huge loss, but his legacy thrives on. Congratulations, Joshua, for winning this prestigious award to commemorate and celebrate the legacy of Professor Lange. Ahead of 26th International AIDS Conference, or AIDS 2026 as we call it, let us rethink, rebuild, rise, and put people first. CNS is an official media partner of AIDS 2026. I would be there in Rio de Janeiro, Brazil at AIDS 2026, and those going to the conference are most welcome to join us on site. Those not going can follow the conference through CNS online. Without any further ado, Joshua, over to you. Please share highlights of your award-winning research in finding more TB among hotspots of Eastern Uganda. Welcome, Joshua.
Thank you very much.
Joshua, we can't see you. Can you please turn on your camera?
Kindly confirm that you can.
Yes, perfect. Yes, perfect. Thank you.
Yes, thank you very much. Thank you very much to the CNS team for reaching out to me to share our work of what we've been in position to do in the eastern part of the country. Also, putting a stone towards what we are trying to build and end TB by reaching more people, reaching them early, and starting them on treatment. I was honored to present our work at the 20th Interest Conference, and it was also an honor to be given the award that honors a key scientific figure and leader in the AIDS epidemic. So my name's, again, I'm called Clark Joshua. I work with Baylor Foundation Uganda, a local NGO that supports HIV/TB programming by working with district local governments and healthcare workers, and also the community teams in the same regions of Eastern and the other regions that we support in the country. In this presentation, hope this is visible. I have decided to maintain the original a presentation that we did, focusing around, we wanted to illuminate hotspots. How do we use data and a mobile van to ensure that we accelerate TB detection in the eastern part of the country? This work was supported by the Baylor Foundation Uganda, which I do work for, but also with support from the American government through the Department of State. I have no conflict of interest or nothing to disclose. As part of the background, we see that close to a half of the population have little or no access to chest X-ray, digital imaging, or diagnostic imaging, which would be a suggestive tool in finding TB. We also see that despite expanding facility-based screening, waiting for the community to come to the facility, most of them actually have conditions. And these are the people that we do screen. Despite this expansion, by September, we still had a sizable proportion, about 40%, missing TB. In that same period, around 2021 to 2024, the country was fortunate to, through some donations, to receive some X-ray tools, portable, as we see in the picture there, and also we had one mobile van. So with these tools, we were not reaching the target of the number of screens we were supposed to do, but also, despite having these tools, it was impossible, or it was a bit difficult for us to get yield. The yield coming from the tools at facility versus those ones who are doing symptom screening was the same. But we also realized that we had a number of untapped signals. For example, when we looked at our EMR data, we had signals around TB case finding. We've digitalized our HMIS around TB, meaning that we have the paper-based system, but we also have the digital-based system where we report them in the electronic case-based surveillance system. We also have community active case finding logs that are also digitalized. We also do have the digital contact tracing. So all these were signals that were ungranular, we were highly granular and spatial temporal. So we wanted to look at them. How can we use these signals to ensure that we reach the 40 missing cases? What did we do? We went ahead to develop a hotspot engine by picking all these spatial temporal signals from the different data sources. We created a data mart using Power BI from the different spatial temporal signals or the data sources. We used this to generate weekly micro catchment risk maps. This, because we were getting this data on a weekly basis, on a monthly basis, we were in position to optimize. We created also an optimization layer, which would let us know exactly where we needed to go. It would input historic data, calculate proximity of the different hotspots that they are identifying. Then it would give us time-weighted targeting. So we would know that from this hotspot, we are moving to the other hotspot, we are moving to the other hotspot, thereby ensuring that within the schedule that we have in that month, we're in position to reach the high burden hotspot. So we did this using the kernel density tool in GIS. Now, when you look at the patient's journey, for example, if we went to this hotspot.
Joshua, is it possible to interrupt me? Forgive me, please. Yeah. Is it okay?
Pardon?
Is it okay to interrupt you for a minute? Yeah, is it okay?
To
Hello?
interpret?
Yeah, no, I just wanted to say that can you please go back to the previous slide?
Yeah.
This is very important because there are people here in this session who have been like Ravinder, for example, Ramful and Nathu and others who have been working with and Dr. Sood and others whose teams have been working with high risk populations. But then, can you just explain this hotspot engine a little bit more in simpler language? Like, how did you, how was this GIS thing was working? Can you just simplify a little bit more so that maybe this is something which is adoptable here? Yes. Thank you.
Okay. Thank you very much. Okay, to make it a bit simple, at health facility level, when a patient comes, they input data into the HMIS tool, like the UniTB register. But that has been digitalized. So in our country, all the data is put into a digital platform like DHIS2. That is based on DHIS2. Similarly, when we go to do contact tracing in our region in Eastern Uganda, we use our cell phone. So we have also digitalized that process. Again, we have EMR extracts that we get from facility where they enter information around the continuity of care for HIV client, their chronic care. So from all these data sources, we were in position to merge them using what we are calling a tool called Power BI. Now, from there, we put this data into a tool, which is a geographical information system, and drew maps. So we're in position to draw map of where the hotspot is, as we shall see in a certain slide. So these hotspots, because now the tool was also giving us recent events, we were not using data of probably 2 years ago. It would also give us, as the new cases are diagnosed, we're in position to know in this place we have 20 TB cases. So this is a high risk area where we need to take the mobile van. So we would use the old data. For example, how has this village, how has it been notifying cases in the last 1 year? Then in the recent quarter or in the recent 3 months, how many cases have been diagnosed, or how many people have been diagnosed with TB in this same hotspot? So that is the hotspot. That's what we would define as a hotspot in our engine or hotspot engine. I don't know if that is a bit clear.
Yes, it is very clear. Thank you so much, Joshua, and forgive me for interrupting you. Please go ahead.
So at the different hotspots, we would, or where there's a higher concentration of TB clients from our hotspot engine, we would, most of these mobile vans have tablets where we, at the hotspot, working with a facility that is in proximity to that hotspot, we would register the clients' names, all their initials, get their consent, but all this would be paperless. And this was because not to help us to be in position to trace the client, easy traceability, but also to pick this data in case that this data, we're in position to get some cases, we can be in position to input it back into our tool, and it help us to refine our hotspot. So we'll do geotagging to know which location we've gone to, and feedback this information in our data mart. At the individual, the clients that we've screened using the X-ray, of course, it has a card for TB, and the card for TB score we were using at that time was 50%. But currently, because of the revisions in our guidelines, we are using 30 for community screening. So every client who had a card for TB score of below 50%, of about 50%, we would pick a sputum sample and send it for molecular testing. In addition, if someone had a card for TB score less than 50%, but was presumptive, had symptoms suggestive of TB, we would also pick a sample. For the ones that were diagnosed, given that the fact that this machine came with a molecular testing machine, a GeneXpert machine, we were in position to get results there and then. And for the ones that had a card for TB score above 50%, but maybe the GeneXpert was negative, we linked them to for clinical discussion with the team there. So this enabled us to digitalize the workflow, have to support consent, registration, and geotagging. And it also allowed us to easily trace which hotspot, what are we getting from each of the hotspots. So just to show us how the hotspots, the maps that we were in position to draw. So this picture shows us in that period of time in the September, these are the hotspots that were picked out from our data mart. And as we can see, and this van shows where we were in position to go in terms of access. This is Mount Elgon for the colleagues here on call. We have a mountain in the eastern called Mount Elgon. So you can see that these slopes, these are some of the slopes in Mount Elgon. So for some of these areas where the van couldn't reach, that's where we sent the portable X-ray machine. And these are the individual TB patients that we got. For example, these points relate to the individual TB patients from the electronic case-based surveillance system data. So we were in position to tune and fine-tune and get to know which hotspot actually would yield the most given the different data sources. On the right here, we see up to my right, in the 109 hotspots in the 8 districts, we screened 2,422 individuals, out of which we had 417 with abdominal X-ray, having a card for TB score above 50%. We collected 417 samples from all those who had abnormal, and diagnosed 61. All these 417 accessed a molecular test. We were in position to diagnose 94 TB cases, 94 clients with TB, of whom 61 were bacteriologically confirmed and linked them to care. Another finding that we actually realized was that, yes, we also picked samples from those ones who didn't have an abnormal X-ray, but had symptoms suggestive of TB. And we diagnosed 15, of which 10 were bacteriologically confirmed. So meaning they had a normal chest X-ray, but were in position to diagnose them with TB, meaning probably we might have intervened early before there's a lot of pathology or invasion in the lung. When we did compare this with previous screening, where we only, in the same campaign, where we only did symptom screening, we see that there was a 10% difference in terms of yield. From the 5,000 presumptives that we got from traditional symptom screen and diagnosed 69 cases, here we only had 417 abnormal X-rays, and we diagnosed 109. So when we compare the different yields, we see that actually it was a 10% multiplier effect. All the cases that we diagnosed were confirmed using GeneXpert. our three game changers were that yes, for us to reach the hotspots, it was data driven, and also us drawing the maps of the potential hotspots using historical data. The AI-powered point-of-care mobile van, meaning that we were in position to do everything, including screening for non-communicable diseases in this van, and also digitalizing the whole process, meaning that the data that we would get, we would have no data loss in any way. But also, this data would help us to fine-tune our hotspot engine. So we think that by integrating routine surveillance with an AI-enabled mobile chest X-ray platform like we already have in the country, and geospatial targeting can increase our chances of getting TB cases in those high need areas, which is actually scalable, because in this event of resources reducing, we need to reach the populations that are highly at risk, but also highly need the intervention. So far, what has happened
Joshua,
as
I'm
a
sorry.
country?
Hi,
Yes,
Joshua.
yes,
I'm
yes.
sorry to interrupt you, but can you go back to the previous slide, because it will be very helpful for all of us to understand. Can you
Yes.
please tell us more about what is in this fan in terms of devices and stuff? So it will just help us understand. You mentioned NCD screening as well, so it will really help us understand and relate more. Yeah, there are a lot of people in here on the call, like Dr. Sood and Humana people, to people India people, etc., who have been similarly doing this. So it will be really helpful. Please, sorry to interrupt you again.
Thank you very much. I was trying to write them down. First, of course, we have the X-ray, the X-ray van that has including, we have the X-ray machine, and then the AI.
So this is like a big, the full-fledged X-ray, or is it like a handheld X-ray? Can you just, and which one? Yeah. And which AI are you using? Yeah, please. That would be great.
Pardon, I didn't get the question.
Yes. So is it a handheld X-ray, or is it like the big X-ray which we find in institutions? And which one, and which AI are you using? Just for, you mentioned Gene Expert, so we just wanted to know which other things you are using. Yeah. And how big is the van? Is it like a bus, a truck? Yeah.
To start with, I think I didn't have a picture here, but later on, probably I can look for some.
Sure.
And I show, okay, it's a big truck. It's a big truck, and inside there's it's similar to a handheld device. If you look at the portable one, I think the technology is the same, just that this one has is the way they inbuilt it uh, is not like the other one for the handheld, but it's similar. And then the AI, we are currently they are trying to upgrade the versions, but um, I'm not so sure now what the current version is, but we were I think the last time I checked it was at 4. But I will be checking
Yeah. Which company is
to
it? Is it,
ascertain.
yeah, which is the service provider? The AI service, is it? Yeah.
Pardon, I didn't get.
Yeah. Which company is it? The which is providing AI? Just for curiosity. Yeah. It's
The
okay.
company that is providing the AI.
Yeah.
Okay, I'll cross check. I'll
All
cross
right.
check.
Okay. Yeah. Just because you
Yes, I'll
mentioned the
cross check.
molecular test brand name Gene Expert, so that's why I wanted to know a bit further, like which are the other devices you are using. Yeah. Yeah. All right. Anyways, please go ahead. Please go forward and also tell
Okay.
us like how are you testing for NCDs using this van? Please. Sorry for this.
Okay. Thank you. So for NCDs, previously, before we saw that when we would go and only do TB screening, we were not in position to get a number of people screened. So we wanted to integrate, because you would find that TB in most cases is not in isolation. You would find that the same client would need probably a screening. The same person can be co-infected. So in the consecutive rounds of where we were going, we ensured that in the van we had among the tools, we would screen for high blood pressure. We would have a BP machine. We would have a weighing scale. We would have mark tapes. We would also include a screening for diabetes, and some bit of strips, the tools if in our screening we found that actually this person is screen positive, we would go ahead and also test them. This would improve the holistic management of the clients, instead of only screening them for TB and then referring them to the facility for other services.
Yes. Thank you so much,
Yes.
Joshua. This is very, very helpful. Once you finish the presentation, you will also hear success stories like from Dr. Sood, etc., who have been doing this already, not only NCDs, but also things like anemia, for example, and they're using very local point of care tests. But anyways, please go ahead. Thank you so much for helping us understand what is in the van. Thank you.
Okay, thank you very much. Additionally, as I was saying, where have we been? This was just only a road to show that where does this study, when you look at the trail of what has happened in our country, where does this study fit? What did it, how did the country take up the study? Or because this was an element of implementation science, as we were implementing in one of the campaigns, because as a country we have the CAST campaign. Every 6 months we go out to look for TB as a country, and it's a countrywide campaign. So for us in the East, we wanted in this September to make it a bit different. We didn't have very many resources to reach all households. So what we wanted to do is, how can we reach the most at risk population? Before the 2021, we were doing symptom screening in most of our facilities. And around 2021 to 2024, the country, in that time, they procured about 39 portable X-rays through the government systems. Others were donations, others were I think through the government systems, they were in position to procure 9 mobile vans. And in Uganda, we have 16 health regions. So you would find that 2 were at the Ministry of Health to support any other regions, and others were located at different regions, but they were not meeting the 16. In the September campaign, that's when we used big data to ensure that we deploy them to high at-risk populations. So learnings from this, the country went ahead to use EPCON AI. Now, when you compare EPCON AI to our study was only looking at using only TB-related data, what we can collect from the facilities. EPCON AI would bring in other contextual information around probably immunization, information around housing, information around any other data that is collected that we may not have had access to use during our September campaign. So this other contextual data would not plus the events data of the different hotspots and the screening would make a better precision of even identifying the cold spots, because for one of our limitations in our study was that you are only looking at where TB patients have already been gotten in the previous years, or where the villages where TB patients are, to predict that this is the village high at risk in terms of numbers. But with the EPCON AI, it can, given the contextual data and which data is important, it can be in position to predict because of the households, because of the poverty levels, because of this other parameter. We think that this village is a potential hotspot. So you can go to cold spots and hotspots, which is a bit different, but we were the first to show that this can be done. Currently, the country has about 79 portable X-rays and 19 mobile vans. So meaning that, and we are using now the EPCON AI to reach these individual hotspots. Currently, again, there's a new tool that the ministry has brought in. It's called the Sync DAI-powered screening platform, which we want to have a similar understanding of screening for all health workers. Uganda is moving towards digitalization of the health system. So we want the screening tool to be on the health workers' tablets, on their phones, such that when they are screening the clients, they have a similar way of screening and also a way that can lead to a diagnosis for those who are still using symptom-based screening, where the portable X-rays or the mobile vans aren't. And we believe this would help us to reach all the people that we need to reach and get all the missed cases and end TB. I would like to acknowledge colleagues that we worked with at the National TB Leprosy Program, the United States government for its support, the Baylor Foundation Uganda, the colleagues, our regional hospital that we work with, the district and city local governments that we also worked with, the persons affected by TB, and the interest conference for organizing committee for the recognition. Thank you very much.
Yeah, thank you so much, Joshua. This was really very enlightening, and congratulations again for the prestigious Joep Lange Award. And of course, you have seeing your work. There's no doubt that you've done justice to the legacy of Professor Joep Lange. As he was, several of his interventions have been around reaching the last mile. And of course, like groundbreaking work like around on HIV science. So thank you, Joshua. So Joshua, just one quick clarification that you were focusing on people living with HIV. Is that true? Or people living with HIV and as well as not? Yeah.
Thank you very much. So to make up the hotspot, for example, we would pick different data sources. For example, from the EMR, because the EMR the electronic medical records is generally for HIV, people living with HIV, looking at their continuum in care. So we would use that data as well to make our hotspot. Now, when we go to these hotspots, we were looking at the general population. Additionally, when we go, for example, to a hotspot in a village W, we would in the first hours of the morning, we would screen the PLHIV or the people living with HIV in that clinic. So the mobilization wasn't for only the people in the hotspot, but we were also looking at the clinic or the HIV or the chronic care clinic in the vicinity of this hotspot. So we'd also mobilize all the PLHIV to come and also get a screening done. And when you look at our reporting, our DHIS to the national system, it has been segregated in a sense that we look at the general population that we've screened, then we pick out, okay, if we screened 2,400. Among these ones, how many of them were PLHIV? Yes, so that could be my answer.
Yeah. Thank you so much. This is very helpful to understand. Before I, invite other people to speak, I'll just like to say that let us hope that with the work life which you are doing and other people in this call and YouTube etc. are doing, is really very important to convert every hotspot into the cold spot. That is a good word which we have introduced today. And Joshua, I will just like to share that Dr. Soumya Swaminathan, who's the former chief scientist of the World Health Organization, she recently said that all the X-rays in high burden settings, like which are used generally in the hospitals for a range of conditions. Like if you have AI there, it can detect TB. So it's a very simple, cost-effective solution when we are doing millions of X-rays in high-burden countries for a range of conditions. If you can just and if it's a high-risk setting, if a high-burden setting, then at least that is perhaps it can be looked at. But it's really great to see that you are also doing NCD screening, and you are very right in when you said that the same person can be with multiple conditions, and you're very true. This is the realities where we live in, and especially of the people who are at a higher risk of TB, they are also at a higher risk of several other health and non-health conditions. And so it is really important to have a more integrated one. We are very impressed with the geo-tagging initiative you helped us explain, and sorry to interrupt your presentation a few times, but we really wanted to understand a bit better how are you using AI and geotagging to identify hotspots, and hopefully these hotspots are converting into cold spots. So this is really good. Um, so, so now let me invite other people who are in this room, and especially actually one of the people who, I think he is perhaps just give me a second. So Joshua, uh, l- let me, sorry to interrupt. I think my computer is acting a little bit funny. So I think I'm the first person. Dr. Sood, are you free right now? Dr. Rajesh Kumar Sood, sorry, Dr.
Yeah,
R.K. Sood is a noted champion not only on TB but I think on health security or health, and he has led from the front, whether it is TB, HIV, NCDs, or other related risk, addressing other risk factors. He has very successfully, um, uh, led from the front, and not only in the TB but other spaces as well. And Joshua, can you what was the maximum number of X-rays you could do in one day? Your team could do in one day with one with
Uh,
one with one X-ray machine.
okay, thank you very much. When we got to the tools at Ministry of Health, they gave us a target. So for the mobile van, per outreach, if it's a community outreach, the minimum target was 100 screens.
Okay,
But
thank
you
you.
would find that when you go to a community, you can do more than that. And also, the other question that you had asked earlier before, the technology that we are using is from Delph TB,
Okay.
and the current versions that we are using are 7 and 8.
All right. Okay. Thank you. Thank you. That is helpful to know. So thank you, Joshua. And Joshua, just to introduce Dr. Sood, one of in his team, Dr. Sood, please correct me. Or he on one handheld X-ray machine, they could do 600 plus X-rays in one day, from starting from early morning to night. And as you mentioned, mountains, it's a mountainous terrain. So it's a very difficult terrain where Dr. Sood also works in Kangra, near the Himalayas and Snow Peak. So Dr. Sood, over to you. Please help us, please respond. And of course, this is a session for cross learning. Over to you.
yeah, Joshua, it's really nice to learn how you're using digital technologies and AI to leverage and further strengthen these systems. Well, in India also, we have a digital platform called Nikshay, in which every patient pathway is tracked. and from the presumptive level till the post-treatment follow-up level. And we are also doing similar hotspot mapping from where we try to develop this high risk villages and based on around 30 variables, which include indoor air pollution and other variables. So, quite similar things are going on, and it's nice to learn that a lot of effort goes into all these this thing. And just like Bobby shared that initially we were able to achieve a huge momentum. People were very, very enthusiastic, and in a competitive mode, 500, 600 x-rays in a single day, early morning to late night, and massive mobilization. Now I think since 2 years down the line, now that mobilization level has dropped with that it's difficult to sustain a very, very high level of mobilization. But still, we are going great daily. Like our team is doing a lot of x-rays and trying to screen more and more people. And my primary take is to put more and more people on TB preventive treatment, because in my setting we are not finding any additional yield. Maybe we have reached the plateau of case finding, but people in whom we can exclude active TB and then put them on TB preventive treatment, so that is the yield for us. So we are trying to push on TB preventive treatment in a very, very big way, because when we turn the tap off, only then we are going to bend the curve of the TB epidemic. So I think really nice learning from you, and very good initiatives that you're taking. And I think we can all cross learn from each other. It's really nice that Bobby. Thank you for putting us all in touch.
Thank you so much, Dr. Sood. You are very right. Unless we turn the tap off of latent TB, because every single case of active TB disease comes from the pool of people who have latent TB, and I could be one of them. I come from a high burden case country, India, where almost half or so, or one third, half, two third. These are the estimates where people could have latent TB, and it's very, very important to screen people. And Dr. Joshua, this is it's very interesting, because Dr. Sood had reminded us some years back that when they are screening for people and who are not do not have active TB disease, and if they're eligible for TPT, why it is important to give TPT. So thank you, Dr. Sood, and it is very important to see that the national program has also taken it in a very big way. So when we say that the India's national TB program, when it is doing AI-enabled X-rays and sending it to high-risk populations to find more TB, it's the largest initiative, I think. We found over 1 million in a year of asymptomatic, and 3 million or so TB cases as per our health minister's report on the World TB Day, last World TB Day. So, but Dr. Sood reminded us that this is also the largest initiative to roll out TPT, the TB preventive therapy. And I myself seen in Delhi, for example, and now I will rather I should not be the one who is talking, because this was an initiative of Humana People to People India with the local initiative. So anyone from Humana People to People India, please unmute and tell us, respond to what our friend Joshua is doing in Uganda. A similar approach you have also have been. He could reach 9 times more people, find more 9 times more people with the disease and link them to the care. And this is, I think, you are also doing, but in focusing on homeless and migrant people. So over to you, Humana. And and I will also request you to please share how you are is screening people living with HIV with AI-enabled X-rays, and the huge difference you could make in finding TB among people living with HIV as well. This is something which should be programmatically taken up. Over to you all. Anyone from Humana, please, or more than one, please be welcome to unmute and speak. Thank you. I think maybe, but anyways, please unmute and speak if you feel like. But Joshua, I would just like to share, and I will share more links with you after this call. They have been really doing amazing work, and the kind of difference which it has made, not only in terms of connecting people who are more at risk with the government-run services, but also in saving lives. This was really important. Ravinder, I saw you unmute, so please feel free to speak. Please go ahead. Yeah.
Thank you. And human people to people in India, we are screening. We are also doing the active case finding through. We are screening all the homeless by X-ray, using X-ray, AI inbuilt X-ray especially. And we are our model. We are working on 9 chest clinics, and our target is to reach 36,000 homeless in Delhi, in the Hattori night shelter and the settlement where they are living. And we are also we are when we find before we are using without AI X-ray, and that presumptive rate is very low. And when we started with the AI inbuilt, because Medanta has the AI inbuilt X-ray, and that helps a lot. And is automatically the presumptive rate is gone very high. And through this high presumptivity rate, we find many asymptomatic cases also. and and then other partner we have also the we partnership with the health go, and they are also using the AI that called Zenki Deep Tech AI, and it's showing it's finding is excellent finding, and we reach many more cases till now. In last 8-7 months, we screened 36,000 people, 30,000 people, and we find 2,910 presumptive and 384 active TB, people with TB in the all over the Delhi. And we also start when we are searching about the how the presumptivity rate or TB cases in the among the HIV people with living with HIV and AIDS, and we found that there is no screening, AI X-ray screening in that all the HIV positive, and they are doing by the 10S or 6S by verbal screening. So we start organize or start X-ray screening among the ART center, and we we simply screen by the X-ray all the, and we found many cases in there. Every 100 X-ray in the HIV, in people with HIV, we found 1 or 2 cases. So it's helps a lot, and the department are also very happy with that. And the other chest clinic, they started also doing screening among the HIV people with HIV and AIDS in ART centers, and they are still organizing camp, and still we are in process. Hopefully we will get the good result when the whole data will come out. We are on the understanding on people, and our approach is to people screen more and more people, and also the close contact screening. And because our close contact screening is low, big TPT intake is low, because our target group is basically the individuals who are living in without family in the night shelters and other slums, degraded slums under the flyover. So this and that area where we are struggling. But I think Dr. Joshua presented very well, and it's true. AI inbuilt into integration with the AI and technology is helping a lot in the finding TB cases. Thank you.
Yeah, thank you so much, Ravinder Bhai. This is really very important. Joshua, I will. I hope you're there, right? Yeah. So Joshua, I will like to invite Tariro Kotadza. Tariro, welcome. Are you there, Tariro? Tariro. So, uh, Elizabeth, will you like to say anything? Anyone else will like to add anything? Please feel free. Agnes, if you will like to talk about your experience and respond to uh, Joshua's presentation. Please be welcome. Dr. Aditayo, please be welcome if you feel like responding. This is the time. All right. Dr. Joshua, any remarks on what you heard just now?
I would like to thank them for I've listened in to Dr. Sood on what they are doing and how also they are pushing for TPT. In the beginning, as a country, we started a campaign. It was called 3x1. And it looked at not specifically looking at X-ray screening per se, but it was looking at contact tracing. So for every one TB patient that we had a target of at least having 3 contacts put on TPT. And by the time we ended the 2022, that financial year, 2022, we had already reached the target. So the current, then in the 2023, 2024, 2025, we had the 6x1. So for every bacteriologically confirmed TB patient, where we do, from whom we went to their homes and did contact tracing, we looked at a target of putting at least 6 contacts on TB preventive therapy. Previously, we were only looking at household contacts, but the guidelines changed to ensure that this contact tracing is extended to even the other social contacts. And one of our findings in one of our papers was that actually we also found TB among the extended contacts. Currently, as a country, we are at average around 5 contacts on TPT per TB patient. But in our region, we are around 6, 7 contacts who are screen negative put on TPT. Still, in most of these contact tracing that we do, I also have a colleague who we work hand in hand. Hood is online. We work hand in hand to support contact tracing. Their organization supports contact tracing, but other activities around MCH, including TB contact tracing. I also have a colleague on call, Diana Chirotin, who we work with closely at Baylor Foundation Uganda. I've also seen on call a colleague we work with, Alphonse Kwezira, we work with in Uganda. So these are some of the things that we've also done to push the TB preventive therapy as we try to look for the TB patients and ensure that they are gotten early and treated early.
Yeah. Thank you so much. Really, this is very inspiring to hear what Uganda is doing, especially your team, and 3x1 and 6x1. This is really important, to encourage people to find more contacts and put them on TPT. Great to learn about this. So thank you for sharing that. That is an important point. Anyway, I think Elizabeth is here. So Elizabeth, will you like to have any word, please?
Yes,
Please be
thank you
welcome.
very much to Dr. Joshua and Dr. Sood and of course to Bobby and Shoba for the initiative. I would just like to add to what Ravinder said before, that we have the number we are screening per day. It is typically between 40 to 100. It depends a little bit about the place where we are. So we have not yet achieved these impressive numbers as you are talking about, Dr. Sot, that would be wonderful. But so far we are typically around 40 to 100 in a day, and that is every day. So that is one point. And we find approximately one person with TB for every 70 we screen. That is like, it can be a little up or a little down, but that is when we see what we have been screening in the last 6 months, this is approximately the number of people we are finding. And here we should, of course, also mention that this very high number, that is from Delhi itself. We cannot say how it is in the rest of the country, but we are working in the very marginalized and dense populated areas in Delhi. And we know that there is typically more than 1,000 people with TB per 100,000. So it is among in these areas that we are screening. And then, as Ravinder told, we have initiated collaboration also with the ART centers, where we have especially found many people who are asymptomatic. In the other areas, we have found approximately, I would say, 1/3 of the people were asymptomatic. But among the people living with HIV, we have found maybe 60% of the people asymptomatic. So these are the results so far, but I would say it's a very good tool, and especially also because people are very interested. We have been working a lot through the last 10 years with making awareness, making information, trying to end stigma and discrimination. And that we have also had a lot of success with. But I would say that when you come into a community with an X-ray camera or a bus that is equipped with an X-ray camera, that is something people are very interested. It attracts people in itself. Lots of people, they are very, very interested in coming forward. So that in itself is also supporting the whole, you can say, come and get screened approach. And also, I would say, is contributing to reducing stigma and discrimination. So that was just what I wanted to add.
Yeah,
No,
thank you.
no,
Yeah,
I
sorry.
actually wanted to say one more thing, Dr. Joshua, and that is that it was very, very interesting with this integrated approach. We also, wherever we have the funding, also try to include minimum, you can say, screening for high blood pressure and also sugar level. But it's sometimes when the funding is low, we can only do TB screening. But it is very, very good to integrate both the screening for non-communicable diseases and TB screening. So if I should talk about an ideal project, that is how it should be. And then just one more thing, we have seen, we have a very close collaboration with the district TB officers. And in some cases, in some of the very dense populated areas in Delhi, the district TB officers and with some of the doctors from the clinics have been out and directly giving TB preventive treatment on the spot when we have screened a person and it has already been clear that there was no TB. Then because of the vulnerability of this group of people, they could immediately start to get TB preventive treatment. However, it is not, I would say, still the norm. It has been among some very progressive and forthcoming of the doctors in the TB clinics. But that's a new initiative. Thank you.
Yeah, thank you so much, Lisbeth. This is really very inspiring. And Joshua, you will see that you are not alone, and there are so many people who are trying to do similar things and to serve especially the underserved. And this is really very important to hear synergies and so many reflections from other people as well. Uh, I'd like to add to Elizabeth what she just said. It's not just about integrating different diseases or infections, but I've also seen personally that how their initiative, like for example, SWEET, which is the street women or homeless women or migrant worker women empowered to end TB, I think if I remember correctly, was supported by Stop TB Partnership, I think brought in gender perspective as well. So there are a lot of ground realities, the realities of people's lives and which are how it affects TB access to TB services. I think that is so important how Humana and Dr. Sood and Joshua Clark have been, or Agnes, for example, who is in the call, are trying to address, or Tariro, if you are hearing me, if you can unmute yourself, it would be great. Are you there, Tariro? Uh, Tariro Kotadza, are you there? All right. Anyways, so I think he may be having some tech issues. Anyways, so Dr. Joshua, any closing thoughts? Anyone else who would like to speak? And before we end the call, and Dr. Joshua Clark, I think this is a great salute from our side, because we initially, when Dr. Joshua Clark and I were discussing this session, I think we thought that maybe 30 minutes will be enough. But even it's more than an hour and the discussion is going on. So this is really very stimulating for me personally, and I hope it's not boring for others who are here or watching us on YouTube. So Joshua, any final thoughts? And anyone else is also welcome to speak. Thank you.
Again, to thank your team for inviting me. We've also learned a lot from colleagues and what they are doing. And we think that having a village of learning like this will not only improve how we learn from each other, but we can be in position to find and reach people who need the service better. You said something around mobilization. True. The numbers, we also had that challenge around mobilization. You find even hitting the 100 screens per day is actually a challenge in some of the outreaches. So what we've tried to do, we know that currently the world is digitalized. Most people have very many smartphones. So we've also started to become a bit trying to go towards that trend, ensuring that we make flyers or posters that we can give health workers to share on the different groups they are on, showing the schedules of where the van is, using the village health teams, because in each of our villages in Uganda, we have village health team members, at least 2, and they do have megaphones. So on days before when the van goes there, we are trying to ensure that they move in within the village with their megaphones to announce when this van is coming, and for the people who need the service to reach out there, including the radio talk shows and also the district team members that we engage, plus the political team. So we've seen that with this engagement, we're in position to increase at least the number of individuals that come to be screened. So we also think that when you go to a hotspot, for example, and you spend only a day, you might find only the people who are available. So the other thing that we're trying to do is to increase the number of days in the hotspot. Instead of having 1 day, probably we can be there for 2 days. This because the people who are screened were thinking that the people who have been screened will go back and tell others that we had a survey somewhere there. So on day 2, day 3, we see more influx in that individual hotspot. So instead of staying for 1 day, we have been increasing the number of days that we have at the individual hotspot. So by and large, I would like to thank you, the team from the CNS, the colleagues on call. It was an honor to learn from you, to listen in from you, and also share our findings from the East in Uganda, but also the work that we've been doing as Baylor Foundation Uganda. Thank you very much.
Thank you so much, Joshua. Joshua, I'd just like to request you that on 3rd of July, CNS with National Coalition of People Living with HIV in India, and hopefully with Humana People to People India and other partners around the world, especially in Africa and Asia Pacific. We will be hosting an affiliated event around the 26th International AIDS Conference, AIDS 2026, which is in Rio de Janeiro in Brazil, as Shobha had mentioned in the introductory comment. So we will really like you to please present this high impact intervention in Uganda, especially bridging the gap between bridging the gap. I mean, in terms of bridging services for people with TB and HIV. Joshua, in 2009, the head of the UNAIDS, I think Dr. Michel Sedebe, he had told us, I'm just, speaking from my memory, and maybe I'm getting old, so maybe there is a word or two here and there. But what he said was that bacteria and virus has joined hands, but why haven't we? Something on that down. And I think this was so important in 2009 to hear that why are TB and HIV program not working together. And I think there's so much more we can do. There's no reason why anyone from should die of TB, whether of living with HIV or not of HIV, because we have medicines. It is preventable disease. We can do so much better. And same goes for HIV. No one needs to get infected with HIV if we can make combination prevention a reality for all. So, but thank you so much for these insights. What I will do now, Joshua, I will request, of course, for you to be with us on 3rd of July for the AIDS 2026 affiliated event and make a presentation along with others. And I'll send you more details, but also I will connect you all on this call over email so that more sharing and learning and camaraderie goes forward. We are in this together. Thank you so much, Joshua, and super congratulations again for winning the Professor Joep Lange Award for 2026. It's a great honor for all of us, and we celebrate the legacy of Professor Joep Lange. Of course, you must be smiling from the heavens up. Thank you. All the best.
Thank you very much. Thank you.